the decades of practice and you having had exposure to menopause care so early in your career, would you just give a little context for how it is that so many women need hormone replacement, menopause hormone therapy, and yet there's still either explicitly or in some sort of vague way, there's like a cultural meme about it being something we should avoid. Would you just give the context for that reality?
I believe when I was training, I was in a menopause clinic, a mature women's health clinic. And at that time, hormone replacement therapy was quite common. I don't want to divulge personal details, but family members of mine were on it. And so it was just readily available as far as I can remember. Transferring into solo practice, the same thing. There was actually a patch ester test as well that was included. Then I remember when the WHI study came out, and it wasn't so much doctors had a time to regroup and reassess. I mean, those of us that weren't in academia, more or less, we were on the front lines and doing private practice work, delivering babies and full scope. But it was really the women that called and decided for themselves based on media attention and what they read in the paper that they wanted off. And so, of course, the number of prescriptions declined, whether or not there was discussion in the office or the patient room about risks, like the true risks and so forth. And so it was kind of out of our hands because it was kind of direct to consumer. You know, the WHI and the press conference went straight to the consumer. About a few years after that, I became a stay-at-home mom and raised my 5 children. And during that time period, I stayed current with, my boards, and then eventually later going into telehealth, which I went in several years ago. When I reemerged back into the space, it was very interesting. It was very different. It's still, people were not prescribing hormone replacement therapy. And then there was talk about reanalysis and really looking at the data. And in summary, what turned out to be is that there are different cohorts, of course, within the Women's Health Initiative. And then we also had other segments of the Women's Health Initiative that were ongoing so that people could look back and scientists could look back and see really what were the risks. And in summary, what we found is within a window of opportunity, which means women that are transitioning within, an average age, like several years before the last menstrual period and up into early menopause, were a different cohort of women, and there were no risks. In fact, there was benefit to being on hormone replacement. And of course, there was the segment in the arm that was estrogen alone based on women that had had hysterectomies for benign conditions and so forth. And they even fared better. So it really prompted reanalysis. And then there have been a lot of physicians in the space. And one book in particular, Estrogen Matters, from a breast oncologist, to really look at the Women's Health Initiative and again re-explain the risks involved and where there are risks or when there's not risk. And so we have a lot of advocacy out there, and we're trying really hard. There's an army of doctors. There's the Menopause Society that has released guidelines in 2022, and patients can download it, physicians can download it. So it's really clear that within the guidelines, and of course there are women that can be prescribed hormone replacement therapy that are outside this window, but the guidelines are stating that it is safe for most women, for the majority of women, and there are benefits to it. And we have been not encouraged to use it. We have not had, there's been a knowledge gap that's also been shown scientifically, that there's a knowledge gap, not even with primary care physicians, but amongst OBGYNs, which is really, really sad. So there's a real push to get OBGYNs all on the same page and at least look at the guidelines and prescribe to guidelines. And then, of course, there are instances in women that could benefit from menopause hormone treatment, and especially vaginal estrogen therapy, that may be outside that age window that we talk about, which is less than 60 years of age and or less than 10 years from the last menstrual period. And of course, this is about the cohort of women that have menopause or transition naturally or on time, not early or premature.
That's so helpful to just lay out the landscape of the various societal inputs. It means that, there's so many things that it's beautiful to be able to ask your mother about, but this probably isn't one of them, because what your mother would have heard is not what's relevant for you. So for somebody who, let's say, is, 48 or whatever, in that age, what is the standard of care? What are those guidelines? I'm not asking you to go through every single guideline, but, a woman's listening, she's like, okay, so that wasn't right. There are new guidelines. What are they? What's the thing we all should know to replace what we've known and has been shown to be wrong?
Yes, terrific question. So most recently, within the last couple years, there have been studies done, retrospectives and surveys actually, that really tell the truth that women suffer and have symptoms several years before their last menstrual period. So there's a real emphasis now on perimenopause and late menopause, and really just being more in tune with your body. And the period is a vital sign. So we don't need to go rush and do laboratories. The period is a vital sign. It should, it's asked every time we walk in, and there's a reason. So it's not just that we mark it. There's actually history behind it. It has served such importance as a parameter of where we are. And is it regular? Is it heavy? Is it abnormal? Is it unusual? What's it been like the last year? So really at age 48, in general, women will be experiencing irregularities with their menstruation. And for some women, it can be very heavy. And this is the time period where, women might be seeking help for their uncontrolled, not uncontrolled, but just heavy bleeding or unusual bleeding, prolonged bleeding. And so at 48 years of age, hormone replacement is generally to help lessen the discomfort, help lessen the bleeding, make sure a woman doesn't become anemic, and to make them comfortable, reassess what their contraceptive needs are. We can still get pregnant at that age, and sometimes we think we can't, but we can. And so really it's actually birth control. Low dose birth control is predominantly the treatment of choice. Now, there are restrictions to prescribing birth control. There are some, and there is the medical eligibility criteria put out by the CDC, and we follow that, and we discuss when it's not a good idea to use combination oral contraceptives, but there's also the mini pill, which is the progestin only, that can also help. There are other modalities such as the IUD with progestin, which is a wonderful option for women in their late 40s, because that essentially eliminates a lot of bleeding, could eliminate your period as well, and then provides nearly 100% efficacy for prevention of pregnancy. And then on top of that, if you have symptoms due to ovarian function in terms of lessening of estrogen levels, then you can add back a patch. It's very easy. And then you can titrate to allow a woman to have relief.